Something terrible happens when people do plenary lectures. They get taken over by the sort of Mussolini inside them and feel that they have to give a kind of grand vision, primary care for the 25th century or something like that. And that's exactly what I've fallen into today. I'm an academic now. I used to be a doctor. I still am a doctor. It never leaves you. And I am very proud of my H-index, because as an academic, you're rewarded for the number of publications you have and the number of citations you have. And I'm proud of my H-index because it's terrible, right? I have really poor performance on all of the standard metrics of academia. And what I want to try and persuade you of today is that, first of all, conventional academic papers are not the answer to improving patient care, but we need people with the skills of academics working alongside clinicians and patients and software engineers and policymakers and lawyers and lobbyists and PR people and campaigners to improve patient care properly and to drag medicine into the 21st century. Because there is this kind of fantasy, there's a story that we tell ourselves, about medicine, which is that medicine is a data-driven enterprise. So we find uncertainties, we do trials to resolve those uncertainties, we report those trials, and then we synthesize the evidence, put it all together, and then we disseminate it, get it out to decision makers, which means doctors and patients, and we implement it, and then we audit to see whether or not it's been implemented properly, and then the grand cycle continues. But every single one of these steps, with the possible exception of doing trials and synthesizing, is done monstrously badly today. And I will whiz through some examples. And just bear in mind, like, I know whenever you do something like this, people want to say, oh, well, that's not very fair, because what about the dissemination center and the getting it right agenda? And the... Of course, there are people who do quite nice things. That's great. But we just need more. Right. First, okay. Here is, I think, one of the most shocking sections of a NICE report, although it's commonplace. This is NICE Guidance 28. This is on diabetes. First-line treatment of diabetes. What's first-line treatment of diabetes? Lifestyle. Nice! And then when you resort to drugs. Metformin. God, this is like the worst, geekiest pantomime ever. Okay. But then what? What do you do if metformin doesn't work? Nobody knows, right? Now, isn't that extraordinary? Diabetes, one of the most common conditions that we see, one of the massive uptick lifestyle conditions. We have long-term preventive treatments that we give people, not for a week, it's not a 3-day course. We give people these treatments for decades of their lives, and we don't know what the best second-line treatment is for diabetes. I find that absolutely extraordinary. So this is a paper that we did, came out a couple of months ago, looking at variation in choice of second-line treatment for diabetes. And you can see there's spectacular variation between, do people choose gliptins or DPP-4s or whatever. Now, first of all, there's cost. Cost is boring. It's not the priority, but cost, if everybody in the country prescribes at the level of the 10th centile practice for cost, then you'd save well over 100 million quid. So that variation, much of which is going to be unwarranted, would save a lot of money. But also, more importantly, why are we not doing trials? Why are we not doing trials routinely at point of care? Whenever somebody comes through, metformin hasn't worked, why aren't we saying, all right, look, there's a big red button here in EMIS. It says randomize. And I'm going to randomly assign you to one second-line diabetes treatment or another. And none of us will ever have to think about it again. We'll get all the follow-up data from the electronic health record. So we'll find out if you've been admitted, if you've had a heart attack. We'll be able to monitor your HbA1c. Not that anyone should care about your blood measures, right? I care about heart attack, stroke, death, gammy legs, blindness, dodgy kidneys, right? Real-world stuff. And we could do all of that, and we could do it practically for free. We could run clinical trials, not for $10,000 a patient. We could run clinical trials for about 50p a patient. So that's exactly what we set out to do. About 5 years ago, I was a bit player, a project funded, one by NIHL, one by Wellcome, and the ambition was, can we do a trial? It was head-to-head comparison of statins in primary care. Over 100 million people take statins every day, but we still don't know which is the best statin treatment regime, especially not then. So we said, well, let's just do a head-to-head comparison, one statin versus another, press a big button, never have to think about it ever again. Now, what do you think happened when we tried to do that? And we tried to do it just to see what would stop us, right? What stopped us? Well, principally, this is why it's important, you need huge numbers. Principally, it was these chaps, the people in the black polo necks on the ethics committees. And they said, if you're going to randomly assign one patient to one thing and one thing to another, then you have to go through a 20-minute long consent process and chat to them about the side effects and everything like that. And I said, well, there is literally no doctor in the world who has had a 20-minute conversation with somebody about side effects before prescribing a torvastatin. That's insane. I'm not criticizing anyone. What I'm saying is there shouldn't be a difference. It should be one rule for the person who's randomizing and the same rule for the person who's not. Because the person who's not randomizing, who's not generating new knowledge, who's perpetuating our ignorance, is inflicting a far greater harm on the population than the person who's randomizing. So they wanted a 20-minute long consent process, a 7-page long consent form. Then MHRA wanted to do site inspections of like thousands. We want to try and run trials in every single GP practice. They said if any cholesterol that's ever taken by any nurse in any practice is ever used as an outcome in your trial, then the nurse in that practice has to have gone through ICH GCP compliant nurse research training. You laugh, right? That's why you can't have nice things, okay? And this is not okay, because patients suffer on a biblical scale, but in a very hidden way when we don't resolve clinical uncertainties. And it's not as if there isn't already arbitrary treatment variation, right? We are inflicting arbitrary treatment variation on patients all the time. If that was a proper postcode lottery, I'd be happy it'd be a cluster randomized trial, but it's not quite, right? So, how do you fix this? Conventional academic papers are not the answer, right? There's no need for people to go around awarding themselves a point on their CV for publishing another big randomized trial in the Lancet or the New England Journal. No individual trial is a worthwhile breakthrough in the world of evidence-based medicine. The prize should be for the person who becomes the Henry Ford of clinical trials, the person who says no treatment uncertainty without randomization. Wherever we see uncertainty, randomize me. You are not protecting me. By preventing me from being randomized, you are withholding valuable information from me and the whole of society. And if you want to get that done, you don't get that done by writing papers. You get that by putting together a coordinated policy campaign that includes lawyers who give people, civil servants hate judicial reviews. I've seen it on the inside. They can't bear it. It's so, anxiety is the dominant feeling tone in academia and the civil service. Medicine is different. We're used to it. But they can't bear it. It's terrifying. So judicial reviews, you need lobbyists, you need PR people to rope in patients and get proper targeted campaigns. And you need clinicians, of course, and you need academic trialists, but they are bit players in this project of culture change. And that is not an academic paper. Next, report trials. Okay, so last time I came here, it was in 2013. It was 8 days after I had twins, and someone had a go at me for drinking Diet Coke on stage. Thanks for that. Anyway, at that time, we just said, I know it's wrong, it's just, anyway. So we just set up the All Trials campaign. So this is a terrible problem. Clinical trials get conducted and completed, and then they never report their results. So we started the All Trials campaign in 2013, and the first thing that happens was this chap here, who volunteered to be our pantomime baddie, Stephen Whitehead, the head of the ABPI, got up and he said, we will not respond to PR-driven initiatives such as the All Trials campaign. Then, in October, I was here, and I sort of told you off because your college had signed a document that said this problem doesn't exist, which I thought was very unhelpful. You happily took your names off it. Very good of you. Anyway, a month after that, about 6 months after this, we were up against each other on Newsnight, and he said, I've never said that. Now, what made that man change his mind is this. Over 800 organizations, including the biggest funders in the country, including patient groups, professional bodies, all signed up to the All Trials campaign. Since then, we've run a concerted program of open public audit, right? We did this paper in the BMJ in July 2017, looking at all of the pharma companies' transparency policies. We did this in JAMA at the beginning of this year, looking at all of the non-industry funders' transparency policies. And spoiler alert, they are worse, right? Pharma is putting its house in order. Academia is slipping horrifically behind. We also do online real-time audits where we update the data every day to show who's complying with the FDA requirement to report your results within 12 months and the European Union Clinical Trials Regulation, which requires that you report your results directly onto the EU Clinical Trials Register within 12 months of completion. You want to see something extraordinary here, something that makes me really angry, and it makes me angry because I got an email today from somebody telling me off for daring to give a comment on this to a newspaper. I didn't find this trial. So here we go, Public Health England. So you can look up anybody you want. Now, these 3 trials, Public Health England, 3 trials, vaccine trials conducted in children, None of them reported onto the register. 2 of them have reported in journals. The biggest one, a trial on hundreds of children, has not reported its results anywhere. 2, maybe 3 years after completion, right? In the context of the MMR vaccine scandal, with widespread paranoia about the medical profession, in probably the biggest medical sort of, fear and anxiety thing of the present day, Public Health England haven't complied with basic transparency requirements and EU rules saying that you have to report your results within 12 months. That's how far we've fallen, right? Now, if you, sorry, I said Mussolini, didn't I? I didn't mean to go quite that far. Is that, wait. Now. And lots of media coverage when you do things like that. But here is the point. Oh, unreported clinical trial of the week in the BMJ. Lol. It's very good, though. You should read it. Every week we do a different unreported clinical trial. Look, they're very popular as well. Journals should publish not just the things that report, also the things that haven't. Anyway, academic papers are not the answer to fixing this problem. This is spectacular waste of funding money, of pharma money, of patients. Patients give their time to participate in clinical trials, and then we throw that trust back in their face by not even bothering to report the results. And then when you start a campaign about it, people act as if that's somehow really impolite to require that people comply with rules and laws that say that you should publish your results. You want to get this fixed, it's not going to be through publishing academic papers. You need a coordinated policy campaign with lawyers and lobbyists and PR wonks and clinicians and patients and technical people, academics, of course, they're going to play a bit of a role. But that's not how you fix a problem on that scale. Next! Right, synthesize the data. We don't have time, but just, it's Cochrane, very naughty, they don't share their data. Who knew? Wrong. Anyway, next. Right, okay. Dissemination, implementation, knowledge into practice. What could be, if you take a picture of me mid-phoneme, I'm going to look so bad. My wife will leave me. Please, really. Okay, so, right, openprescribing.net. This is a thing that we built, and anyone can use it. It's open to literally everybody. Is everybody, who here has heard of openprescribing.net? Oh, lots of you, how lovely, and the rest of you haven't, and you're very bad. Right, openprescribing.net, you can see what every doctor in the country is prescribing. We go down to the level of individual drugs, chemicals, brands, doses, and month by month you can see at the level of individual practices. You can run your own analyses, so you can decide, I'm interested to know, you get all kinds of funny things. So here's one. Pyracyazine, antipsychotic drug I'd literally never heard of. We found this by doing some really interesting data dredging work, which we'll talk about in our workshop at 2 p.m. in room B6, which you must come to. Okay, pyracyazine, antipsychotic drug, I'd never heard of it. 62 papers on Medline ever. Look, it's prescribed by almost nobody, but the people who do prescribe it, it's about 1 in 5 of all antipsychotics. Who are they? Where are they? They're all in... Come on! What? Yes! Norfolk! Right? Now, so you find all kinds of interesting, strange patterns like that, but also there are practice dashboards where you can go, so you can look up any practice. What a terrible time for it to run slowly. It's because you're all looking at it right now. Somebody give them the name of a practice. Somebody who works somewhere that's not doing very well. Give me the name of your practice. Seriously, any practice, but really quickly.
Davenal House.
Who, where? What?
Davenal House.
Davenal House. Can you give me one that I can actually spell? Wait, D-A-V-E-N. Davenal House. That one. Great. Oh, well, it's a unique identifier. So, okay. So we've got a bunch of standard measures. We've got low priority measures. This is NHS England said, please don't use these drugs, and we give you data showing how you compare to the whole population. This is amazing data science, clever price per unit variation. We show you the things, changes that you can make where it's the biggest price cost saving per individual action with a patient, because there's no point in telling you how to save 2p on 1,000 patients. And you can sign up for alerts on individual things. Let's have a look at some measures. And they're broken down. Some of them are safety measures. Some of them are sort of quality measures. Some of them are cost. It's boring to talk or think about cost. Come on! Right, now, here's the thing, right? When you start to look at the scale of variation, you start to see some really interesting patterns, because you start seeing that there are all kinds of things which are alarming. So up at the very top, well, if you've got 5 minutes and 11 seconds left, you really shouldn't interact with live data on stage, should you? Let's find a good one. How about How about this one? All right, yeah, right. So you're right in the middle for the shift from trimethoprim to nitrofurantoin, okay? Now, here's an interesting one. In 2014, Public Health England said, look, everyone, uncomplicated UTI, single most commonly, pretty much the most common presentation in primary care, probably about 2 or 3% of all presentations. And they said, look, we've got to shift. We don't want people having trimethoprim anymore, we want nitrofurantoin. So these graphs are, up at the top, trimethoprim, down at the bottom, nitrofurantoin. Over the course of time, you can see the blue line is the median, the dotted line is either side of the national deciles, so how this practice fits into the spread. And you can see that if you look at the blue line, you can see that, wait, will this work? Oh my God. Hang on. Wait. I want to show you all the practices in. Oh, God. Oh, my Lord. Hurry, little engine, hurry. We've got 3 minutes and 45 seconds left. You can do it. No, don't. I've got to go. No, I haven't got to go. Compare CCGs in England on this measure. Right, here we go. So, you can see individual practices, but you can also see CCGs. And when you look at all of the CCGs, they're ranked by the ones that are the most outlierish at the top, the ones that are the highest for this measure. And we call them measures rather than indicators. We're very sensible and cautious in the way that we present this data, because, of course, there are often good reasons for people to vary. This is running, by the way, across like a terabyte of data. Now, look, here. Okay, so blue line, median. In 2014, Public Health England said, can you please stop using trimethoprim and start using nitrofurantoin? Basically, no impact. In 2015, NHS England say, okay, we'll pay you. And there's a little bit more of an impact there, okay? But here is the thing, right? Look, up at the top, here's a bunch of CCGs who really just very simply have not changed. And then down at the bottom, here's a bunch of CCGs who changed really early and in a really coordinated fashion, right? Now, early and in a coordinated fashion, what's that about? So it's really interesting. If you start looking, you start to see all kinds of really interesting patterns in the dissemination of knowledge through the medical profession, which is worryingly closer to an oral tradition than we would like to imagine. So this is switching from branded Cerazette to generic desogestrel. And you can see here, the blue line is the national median. So the Cerazette comes off brand across the whole population. Everybody starts going to generic very quickly. So that's that drop in the blue line. But some places drop really early and in a coordinated way, like error wash. Some places drop in a coordinated way, so that's a meds ops team who are really on it, but who got the memo about a year and a half too late, and they drop in a coordinated way there. In some places, you get this sort of gradual radioactive decay curve. That's GPs, individual GPs, just finding out for themselves. And some places never get the memo. Now, here's the interesting thing, right? You can run data science across this. You can do all kinds of really clever stuff. So you can detect the breakpoints, which is what we do, and then you can produce numbers for each practice and each CCG, saying, overall, does this practice or CCG tend to change early or late in response to substantial changes in the evidence, in response to safety alerts, and in response to price shocks? And you can see this variation in when people change. Some people change in a timely manner. Some people change much, much, much later. And you can look for correlations between that. Do people who are late on one thing tend to be late on another thing? What does that tell you about variation in care? Because if you say to somebody, look, you do prescribe a lot of rosuvastatin, and that's quite expensive, people will say, well, it's my patients who are weird, not me. But if you can show that it's actually unwarranted variation in care, because for a load of past changes, which were warranted, they did implement them, but they implemented those changes much later than everybody else, then that's much more predictive that this time when somebody's an outlier, that they maybe need some help with targeted knowledge dissemination to get things changed. So we've also done things on things like this. So this is tamoxifen, and NICE said you should offer tamoxifen primary prevention to 8 times as many women. Now, whether or not you disagree with that, you would have expected to see some kind of an impact on total tamoxifen population prescribing. It's basically negligible, basically nothing. I think it's really interesting. If there's an edict and it doesn't get implemented, it's either it wasn't a good idea, in which case you should be listening back to the front line, because people go, when nobody wants this, it's why are you telling me to do this? Or there's a problem that people don't know, and you should get out there and tell them and help them. Like, this isn't about bad doctors. This is about bad knowledge structures. There's the nitrofurantoin again, and it's not about bad doctors. We need a coordinated machine for disseminating knowledge to frontline decision makers that goes well beyond be on meds-op teams, which are sometimes great, sometimes a little bit on the hairy side, okay? Very variable, different skills in different places. Maybe some are good at talking to people, some are good at analyzing data. But we need a coordinated machine for disseminating and implementing knowledge that includes pharmacists, doctors, software engineers. That's how we built that thing. We built open prescribing, which is open to everybody. By the way, had over 50,000 unique users in the past 12 months. We've got things that you can sign up to where we send you alerts if you start to drift in comparison to your peers as soon as you've shifted over just a few centiles using really clever data science stuff. We built all of it with less than 1.5 full-time software engineer. We built the prototype for 50 grand, right? We need pharmacists, doctors, software engineers, epidemiologists, patients, and writers and editors if you want to disseminate knowledge to people. It's not enough to just do clinical trials and then publish it in the journal read by absolutely nobody. Nobody cares, right? You need to get knowledge into action. You get knowledge into action by paying people salaries to go out there and put knowledge into action. Next, because coordinate, not the answer. Now, that is not to say that academics are of no consequence or value, of course. These problems all require deep knowledge of data analysis, epidemiology, statistics, research methods, clinical trials, and patient care. What they require is that funders and universities pay people who have those skills to analyze data, to spot problems, to fix them, but not with the goal being to produce an academic paper read by nobody, but rather with the goal being to produce an amazing machine that disseminates knowledge and finds out what is the best way of disseminating knowledge. A machine that looks for practice variation, not just in prescribing, but we're trying to build the same thing for pathology data now. There's nobody who funds that kind of thing. That, to me, is utterly deranged. Conventional academic papers are not the answer. And if you agree, which I hope you do, then we need patients and coal-face clinicians to tell funders and universities that we don't care about people's H-indexes, we don't care how many papers they published in obscure, paywalled, low-impact factor journals. We demand better service. Thank you very much. Oh, come to B6 at 2 p.m. B6, 2 p.m.